Well, good afternoon, everyone. Thank you for everyone that's joined here in our faculty online lounge, and thank you to everyone that's joining via Zoom. We have wonderful presentations lined up for this afternoon. So it is my pleasure to introduce our speakers. I'll start with Dave Deagle. Dave is the Business Development Manager for 3D CERAM by Cinto America. So today he's going to be presenting on 3D CERAM and the process provider for additive manufacturing of ceramics, which is essentially the future of the 3D printing materials. So followed by Dr. Zandi and then Dr. Al-Rashdan. So I'll introduce our speakers as their time is up. So we'll start with you, Dave. So if you're ready.
Yeah. So thank you.
To have you here again.
Yeah. Thank you to the university and Dr. Zandi for coming in, and Dr. Al-Rashdan for all of your work. And what I'll be talking about here is 3D CERAM. This is the ceramic 3D printer that we've used to make the parts for a lot of these studies recently. This printer is a laser SLA, so we'll go through a little bit about the technology, why we feel that this technology is best for administering and manufacturing of these dental implant components, and then eventually what will be done in the future to make these in production, in full-scale production. So again, 3D CERAM, Cinto America, we manufacture the equipment, the 3D printers that manufacture and actually print the components. We also manufacture the software. We make the different ceramic materials. In this case, the Zirconia is being made for actually printing this material. And then we provide services to those who own the printers or who are working on the development of the materials. So the premise here is that the 3D workshop we have in France, the 3D workshop we have here in Michigan is available for universities like the University of Michigan and other universities to do your initial studies, get your papers written, do your scholastics, because from there, we feel that we will be able to do full FDA clearance within the next year for our process. And then from that, we will roll this out to dental laboratories is where we feel this will be best used. So a little bit about the process. So laser SLA printing, you're basically using a laser as shown here to create a layer. That layer is cured in a photopolymer, and then layer after layer, it gets built up, layer after layer. So we recoat, we cure a shape with the laser, and then we recoat again. So what we're showing here is this is actual parts being made, one layer after another, building up. So unlike 3D printing using DLP, we're printing with the laser top down onto the build plate, and the laser draws a very precise line, whereas DLP prints little pixels in a single layer with low-powered light. This is very high-powered laser, so it can cure a very high-density, high-content zirconia in this case. So this is what we're talking about, the difference between DLP and laser SLA. So digital light processing, or DLP, projects an image onto a mirror that then shines that up and into your curing bed or your vat. It creates a series of pixels, sort of like a computer monitor or a TV screen. Little tiny squares are created and cured layer by layer. And then the part, the build platform drops down, you cure onto that build platform, and then it lifts it back up out of the resin over and over and over again until you create a part. On ours, the top-down laser, the laser is shooting from the top down onto the vat and onto the build platform, creating a cured shape. And then the platform drops down 50 microns or 100 microns, depending on the layer thickness you need. High resolution can be as low as 25 microns. Very thin layers are possible. The other thing, because we're printing it in this direction, top down, we don't need a series of supports to create the shape. So you don't have little vestiges or little connection points that then have to be ground off, which you have on other 3D printing techniques. So the other advantage to laser printing, you're drawing a continuous line with the laser. So the size of the laser spot is very consistent. That laser spot draws a continuous line, so you don't have pixelation or pixel accuracy, where you have to try to align your shape onto that pixel, which is what we're showing here below. If the pixel is 25 by 25 micron, which would be a high resolution DLP, so you can see here a round shape, which is shown in the black and white. That round shape is very hard to create with a pixel because you can't draw a circular line with a series of squares. You end up with something that's shown like in the blue here on the bottom right, where it looks like a series of steps, which for ceramics, sharp corners, steps, pixels like this create stress risers. And we strongly encourage that we use a straight, smooth shape whenever possible. You know, there are curing and ways of sort of blurring those pictures that the software is adding, but you get a blurred line, not a straight crisp one. This is what we're talking about, support versus no support. So in the DLP, you're printing, the part is rising up out of the platform, but you're talking about a small ceramic part, that's not a big deal. You have just a few supports on it. If you're talking about a full dental arch, which is where we're hoping to get to someday, that becomes pretty massive, and you would need a lot of these support features that would then have to be ground off in some way, which again, grinding on the ceramic creates potential for problems. With ours, we're using gravity to help us so we can do minimal numbers of supports, and we can actually just set the part on a shape and have contactless support. So the slurry is so dense and so thick, it's sort of like a milkshake, and it's actually able to sit and just rest on top of a supportless structure. So just briefly talk about the printers. We have 3 different sizes. There's a C101, which is what we use for Dr. Al-Rashdan samples, Dr. Zandi's samples, mainly use the C101 lab or the C101 fab. This is something for the university level use, occasional sampling. The C1000 is what's used in sort of a dental lab. It's what's currently used to make orthodontic brackets, things of very high volume, but every single part is unique and every single part can be customized. So you could print in a month or a week, you could print thousands of custom parts. Each print bed could have 1,000 unique part numbers on it. So if you wanted to do unique custom abutments or copings or crowns, and each one of them individual and patient specific, you could make several patients, 30 patients worth of individual teeth or individual abutments or individual crowns, or maybe the entire package could all be printed in one print. And so you can see how that would lead to an efficiency, a feasible means of manufacturing in the future. That would be on our C1000 size printer. And then we have a C3600 size printer, which is 600 by 600 by 300. So you could do an immense build platform for mass production. So we do intend for this to be used at the university level, let people learn how to use this equipment, and then scale it up for mass production. And that is the goal. Mass production, feasible means with just gradually growing the scale of the production. So that's a little bit about what this technique is and how it's used. Okay.
Our next presenter is Dr. Zandi. So it's my honor and pleasure to present you today. Dr. Zandi is, it's a very long CV, so I'm going to have to summarize it for everybody else's time. So I'm very proud to read through this. Dr. Zandi is a full-time prosthodontist at the Implant Dentistry Associates of Arlington, Texas. He completed his dental training in 1996 and continues education by finishing multiple residency programs, including operative, AAGD, and prosthodontics. He served as a tenured associate professor and director of the AAGD program at the Texas A&M School of Dentistry till 2022. He's an author and or co-author of more than 80 scientific manuscripts and abstracts, served as reviewer for numerous scientific journals, and holds multiple patents on new prosthetic design using 3D printing technology. He lectures nationally and internationally on new technologies, 3D printing, ceramics, implant, and aesthetic dentistry. So it's my honor to have him today to learn more about the updates in the 3D printing ceramics. And I know Dr. Zandi is also on the speaker list for our upcoming annual American College of Prosthodontics meeting. So I'm also very happy to see him and listen to him over there too. So Dr. Zandi, thank you for coming to Michigan. Thank you for your presentation. Always yours.
Thank you. So before that, getting ready, I wanted just to thank you, University of Michigan, Dr. Sackbig, cross department, cross program, and also Cinto 3D Saran for making that happen. I'm really honored to be here. So although I'm in a private practice full-time since 2022, but I have been in academic for a long, long time. Today, when I walked to the building, to be honest with you, it was a very good feeling. Reminds me many old days that I used to be and teach my residents or be involved in the cross residents for supervising them, seeing patients with them. And it was a very good environment, not only to teach, to learn as well. To be honest with you, many things as a bright mind, you bring up as a question that opens the door to a big research. And I have been through that myself a lot. So asking questions, and then I go ahead, look for the answers, and I see that, okay, haven't them been done? So that opens the door for the good research. So thank you so much again. If the presentation is ready, we can start. Yeah, that's it. So a short movie quickly. Thank you. That was my last affiliation. Now I'm in a full-time private practice. So my lecture is contains of few parts. The first part is I'm going to talk about the zirconia. Why zirconia is important for us and why we putting too much attention to it to basically change even the fabrication technique. So obviously, because I'm lecturing to a group of clinicians, I added some clinical pictures as well. You can interrupt me at any time. We can discuss and answer the question as we go. So the topic is 3D printing zirconia in clinical dentistry. But why zirconia? It's a biocompatible material with a very good aesthetic. I know that it sometimes look very opaque white, but we can change it. We can change the shape, and most of you know that as well. And also its mechanical properties is very, very good. Mostly when we use the content of 3% yttrium. However, as you add more translucency by adding the content of your yttrium to the 5 or 8%, the mechanical property drops. But it still is comparable to your glass ceramics. That's one example of it is lithium disilicate, right? Or EMAX. It comes in a white powder, and then they make it right now as a pulp for milling, but the new technology of 3D print. What is the application in clinical dentistry? So we make a frame for fixed partial dentures, single crowns, implants abutment, implant supported crowns, and even hybrid abutments. So just a case I add for you that zirconia today, mostly if you basically use the translucent zirconia, can be very mimic the optical properties of your enamel as well. And I just put a patient for you here that is almost a 10-unit zirconia. And in the past, we used to do the layering technique to get the translucency, but now maybe with more translucent zirconia, with the staining technique, you get a very good, decent aesthetic from it either. And we can extend it actually to implant as well. If you recognize, I'm not sure that you recognize which one is the implant crown, but number 7 is the implant crown. As I go at the end of the presentation, I explain that there is some criteria to get a really good restoration for implant in the aesthetic zone, but to be honest with you, there's many factors placed. One of them is the soft tissue thickness. And if you don't have enough soft tissue thickness without zirconia abutments, I don't think that you can get a nice pink aesthetic, because the light reflection under the thin soft tissue is not presenting a good shade if you don't have a ceramic under your thin soft tissue. And we go over that. So what I do, and we can actually extend that application now to the full arch cases. And this is what I do in daily basis now for the past 2 years, day in, day out. We do about 250 to 300 arches per year. And zirconia, to be honest with you, has been a great help for me because the patient acceptance is very hard, very high. My failure rate is very, very low. It doesn't need the maintenance that the hybrid model used to have it. And aesthetic part is very good and, more important, very biocompatible. You may not believe that even when I have some, not exactly a perfect flat surface, even I have some concavity under it. Sometimes it happens because of the tissue shapes, and still I get a beautiful soft tissue result, which I have in pictures. And another case, that patient is completely edentulous, and zirconia restorations is completely changes the life of the patient. And the failure rate for that, although there is many factors that we have to consider, but the failure rate, at least in our center, is less than 2%, which is to me very, very interesting. And we have a long-term follow-up of some of the patient about 5-6 years now. So this is the patients after providing that. You can even use a layering technique to make the soft tissue very aesthetic as well. And that was what I was talking about. That's a follow-up, I think, 2 years. I removed the prosthesis. This is what you see under the prosthesis. Soft tissue is really healthy and good. I get it with the hybrid, to be honest with you, but not as good as ceramic. Ceramic is very biocompatible, very easy to cook. What I said is not just my personal opinion. You can look at the evidences. There are good papers out there that talking about the longevity of that. One, I think that is what Abishai Vidra published a few years ago, which shows that the failure rate, success rate is very high. And the one that normally is not, when they follow up, see that what the problem comes is a technical problem from the dental side, dentist side, or the lab side. So if you follow those guidelines, you really get to a good success. Now, that was a brief introduction, why zirconia and what we can do with zirconia. How we fabricate the zirconia. The only way to fabricate zirconia right now, the gold standard, is milling, right? So we use a puck, or you use a block of zirconia. You have created the design, STL file, and that you can basically mill the abutments.
Overheated, and then just like, well, now.
I think somebody
else. So this is, although this is the gold standard, there is some limitation when we look at the milling. One is the using excessive material. So you use a puck, and it depends on the puck size. You nest it very well. Still, you may not be able to use that puck anymore. So the rest of that zirconia is wasted. Also, unusable wastage. That means that you cannot use it anymore. It's gone. Limitation in producing detail and complexity. And this is what I want to talk about. So what is the size of your milling tools? The smallest one you can get in the market about 0.5, which is 500 microns or 0.3 millimeters. Is that right? Can't go less than this. So if your details is less than this, you miss those details. This is my personal opinion. I could be wrong. I think that even the prep guidelines, when we move to the digital dentistry, should be changed if we're using the milling, because some of the sharp edges you're creating on your prep may not be able to duplicate it when you mill the restoration, mostly the Intaglio. And the other one is that complex geometries, which I get to it. So I have some pictures that's showing that how it's impossible to create that geometries with the milling because you don't have any access to it. And the final one is that the cutting instruments or cutting tools you're using, you constantly have to change it. Otherwise, if you don't do that, you may cause some micro cracks during which later on will cause propagation and a failure. So constantly need to use a milling tools and change them, and that add to your cost. So another technology for creating an object is a 3D print. As David said, it's additive technology, means that adding layer by layer, and the thickness of that layers depends on the resolution of your printer on the Z-axis, okay? So however, if you use that high resolution, you get control over every single layer you create on that 3D print. So the advantages of 3D printing, I put them back here. Some of them are really Dr. Sample. Sorry that I'm feeling. So some of them are really, although I'm interested, but more going to the cost effectiveness of it and maybe the lab part of it, which is important, but my interest normally comes to the details and how that helps me chairside when I provide treatment for my patient. So definitely is a mass production. You can basically, depends on the tray size, you can print many restoration at the same time. Sometimes added a little bit time, but not that much. Reduction in manufacturing time, obviously. Do you know that it's very interesting? I'll just tell an example. I have a friend, basically, they have a milling site north of Dallas where I live. And I had a tour with them. So they just invested $1 million on a 3D printing metals. And I asked Nancy, why you did that? He showed me a frame to replace the mandible when you splint the mandible in fracture cases. And it was milled out of the big part of the titanium. She asked me, do you know how long that takes to be milled? I said, no. Believe it or not, more than 10 days constantly. And she said, with a laser printer, I can print it about 18 hours. So that's saved lots of time and resources for you. Obviously, the material can be used again. You use it in your clinic every day. The resin, as long as it's not dirty, you can basically put it back to reservoir and use it. My interesting one, facilitate the production of complex geometry. So that skull back there has been printed by MedCat. Can you really mill that? There is no way that the milling can get to those details inside, unless you make it layer by layer and then add them together. However, a printing system, because it's layer additive, can do that. Not only the basically shape, also the color as well. And we have printers that they can use new colors, right? Interestingly, control the properties during that manufacturing. If you use a printer, which we have, like jet printing, like Stratasys, with different reservoir, if you use a different printer with a different reservoir and color and resins, you can print different materials into it, and hopefully that soon comes to ceramics as well. There are different technologies for the additive manufacturing of the zirconia. I just put a couple of them, the one that I use, and I have been using 3D ceramic. I use DLP with the litters sometimes as well. I'm very happy with the 3D ceramic. The quality of that printer and the print, that's what I have no financial interest. I use the product because I think that is really good. For all the reasons, she's not FDA approved yet, but I hope that is coming very, very soon. So I put a couple of printers that there are in the market. Again, my research, everything that I basically present today has been done with the 3D surround. Here, that's a printer. I don't go over that. We just did a literature review. That's a publication, goes over the different technologies, advantages, and disadvantages. David covered that part, so I just bypass that, go to the next. So the accuracy of that 3D printing was very interesting for me. This is the animation that how it works. You basically feed back there the ceramic. Its paste comes down to the building platform. Then if you have any comments, you can do that. And then there's a conveyance on your STL file and create the shape that you expect, which can be a crown, full arch, an abutment, and etc. It has a high accuracy, high resolution, and very smooth surface. Now, as a clinician, we can't just accept whatever comes to the market. You know, we are responsible for our patients. I have to make sure that whatever I go back there, place it, it meets some criteria. And that's why we have the check and balances. FDA comes in, asks you about biocompatibility, asks you about mechanical properties. So because at the time that we started, we didn't have that much information. So some of those research has been done with our group. So I go over that. So we wanted to make sure that the mechanical properties are there and optical properties. So we started with the mechanical properties of 3D printing zirconia. If you look at the papers they published in 2017-16, you may see that the milling was better than 3D printing. As the new papers comes out, we see that actually additive manufacturing or 3D printing is better than milling. However, that can be a little bit debatable, but for sure I can tell you that the mechanical properties are the same, if not better, for additive manufacturing. And those are based on the publication. That's based on the ISO standard. So ISO standard is good to start with, but however, we have to do some more tests as well. I don't know if you're familiar with the fracture resistant test or not. This is a mechanical test, but it basically, you're putting it in vitro, right? In the bench studies. So we did that study with a milled abutments, zirconia abutments on the Straumann implants, and then we fabricated milled zirconia, milled lithium disilicate, and also 3D printed zirconia, and also alumina reinforced zirconia, which has 20% alumina and 80% zirconia. And interestingly, it was milled zirconia. There were no significant differences between them, and a study was published in 2018. However, interesting point for me was all of them fractured at the abutment level. So I really could, except one, I think that one Emax fracture as well. If I have to do and we do that study, definitely I will use a titanium abutment to be able to see the differences between them. But is it relevant? Maybe not. The maximum forces we get back there, how much is it? Maybe 600 to 900 Newton back there. So it bypasses that. It's about, we are talking about 1,200. So it bypasses your occlusal forces. However, fracture in ceramic is not like that. Fracture in ceramic, sometimes ceramic work for 3 years and then you put 120 Newton on it, it fractures because it had lots of crack on it and you needed one more push, those crack propagate and fracture. So we need to be very careful about those numbers as well. The clinical performance is very different just from the numbers. So the properties of the 3D printing zirconia. So I talked about the fracture resistance. Now go to the marginal and internal integrity. We did a study back there as well. In 2018, to be honest with you, we see lots of marginal defects, and milling one was outperforming the printed one, but the new crown that I just received, is completely a game changer. Now I see that the marginal integrity, internal integrity outperform. If it is not the same, definitely outperforming the milling now. So based on what I said so far, Are you convinced really to use the 3D printing rather than milling? Be very honest. Tell me yes or no.
Yes.
Let's review it quickly together. The mechanical property was almost the same. The marginal was not the same, getting the same. So what is the rationale to use it? At this point, I'm not convinced. However, the second part of my presentation is different. It is how creative we can be with the additive manufacturing. I'm not using 3D printing zirconia because it's stronger than milling, to be honest with you. And I'm not using 3D printing zirconia or 3D printer because it gives me a better marginal integrity. I'm using it because it gives me a better properties. And also I see lots of potential in the future with it. It can do many things that 3D milling cannot do that. Complex geometries and controlling the biomechanics layer by layer. Let's look at it and see that what we can do. It just basically question what? Milling or 3D printing. So let's see what 3D printing can offer that I'm very, very interested about that. So one of the things that in new modern dentistry is coming is being able to be conservative. You don't want to remove enamels. And then, I mean, when I was training, PFM was almost gold standard. I mean, your prep should be 2 millimeters, right? To get a nice, beautiful steady. But right now, you don't need that. We know that it's 0.5 millimeters onlays, top table. If you design it well, bond it to superficial enamel, you can get a very, very good longevity out of it. So bonding is very important. Look at one case here. That case is a extensive, they call it, what they call it, basically when the crown and root are not in the same angle. So ortho couldn't do anything about that case. However, it does not interrupt the occlusion. So the only option was removing that to replacing with implants. In a 17 years old young man, I'm not going to do that. I'm not sure that honestly with implant dentistry after extracting, I can have enough bone to provide a beautiful restoration. So the other thing was a very conservative veneer. And that's on the left side done with the lithium disilicate. Now, if we extend that treatment to use zirconia for such a treatment, definitely we need to make sure that the bonding is strong. Another case, I think that research is about that, the next research coming, bonding the metal coping, titanium copings to the zirconia. It's one of the failures, right? We see that it gets debonded. Mostly if you don't use the protocol, because bonding to zirconia, although is approved, I don't think that is same as the glass ceramic yet. So bonding is very important for us. And also sometimes it's really in a clinical dentistry, I think we talk about, okay, you have to do that, bone reduction, implant has to be placed here, okay, all of that. When you do lots of cases, you realize that it doesn't matter what you do. Some cases go out of your hand. Implant placement, bone is not there. Angulation is wrong. Whoever did the smile design is wrong. You want to correct it, you have to push the prosthesis back. Now screw axis come from the bubble. We all see that. When you practice a lot, you will see some failures. We will be smart if we try to minimize our failure. I don't think that you can avoid failures and complications. They always will be there. So, however, a good clinician should be able to manage them somehow. So we basically saw that case was designed outside, came back to us. When I corrected the smile design, screw axis was coming from the buckle. So what we decided to do to put a veneer bonded back there to cover the screw. So what I need now, bonding again. Bonding to zirconia become very, very important for me. And that was what we did. So we use basically bonding to zirconia. I think that is approved if you look at the literature, and there is a protocol for that. The zirconia side should be sandblasted and cleaned, right? You have to control the pressure, otherwise you cause the micro cracks. So the pressure and the particle size of alumina should be 50 microns. So it's important. Then You can actually use a primer like a Z prime, it has NDP or 4-meta in it, which actually has affinity to bond to any metal oxide, and zirconia is a metal oxide, zirconium oxide, and then you use a dual Q resin cement to bond it together. But do you really get a best bond? Maybe not, because the texture is not there. The roughness is not there. The edge pattern is not there. And that's why you need to be cautious about it. So we did a study. The first step is that proving that, okay, the 3D printing zirconia does have a bonding almost similar to the milling. Yes, if you follow the same treatment, at the end, you don't see any differences. The small difference you see, it was not significant in my article, if I remember it well, the statistics. However, the question was that, interestingly, we did find something here, and that was the roughness of the milled one was more than the 3D printing one. So that could explain a little bit bond strength, but without any extra treatment or design, they almost come at the same. But what is fascinating is going back to that vision of 3D printing, what we can do. You can customize your surface. That I was fascinated with that research that they did lots of roughness on it. We started with porosity, and my concept was that I need something like the edge enamel pattern or the edge dentin pattern. If I can, as you can see that on the top right, it's a dentin, clean dentin side with the tubules, and down is a 3D printed that mimics that. So my concept was that if you do that, you should be able to get a good bonding factor by the tags you created. So we started that with some resin 3D printing, and then we did a ceramic 3D printing as well. On that, we actually could create different porosity size with different distances with them. Still working on that, on the how to really that texture needs to be to give us the best bond for the intaglio of the restoration. The preliminary study we did actually that hopefully comes out. I don't know if it's the same journal or not. We submitted that too. So we did a control. On the control side, we had air abrasion with 50 microns and the pressure application of primer on it on the control. And on the 3D printed side, we did not do any treatment to see that it. Do you know that why I didn't do any treatments? When you apply sandblasting, you may not realize it, but in a long term, you're decreasing the longevity of your zirconia because you're creating cracks on it. And any cracks can absorb water and degrade the internal structure. So we wanted to see that if we can bypass that, no sandblasting, just using the, actually the result came out good. We have 3 groups, different design, but in a design of P200, without any treatment, the bonding to the 3D printing zirconia was more than milled one with the sandblast and prime. That's a lot. And if you don't use the treatment on the control, I guarantee you that it goes much, much less than this. So that shows the value of the 3D printing, how customized you can be. And that's just get more and more to clinical dentistry. So this is the result of it too. In this one, we actually, as you can see that it's controlled, and this one shows that the one that with P200 was more than the control group. And this is the megapascal on the left side. Sorry, I didn't put the numbers in. Can we go even further than this? Yes. You can actually do the same thing on the restoration as well. If you have a veneer, you have only, you can create any texture on that and then print it out, as long as the resolution of your 3D printing is compatible with your design. Now, any questions so far before I go to the implants and the aesthetic to show you another application of that?
What was the study that showed long-term cracking will occur in zirconia?
I don't have it on top of my mind, but I can get you because this is in my discussion, my paper that I submitted. There's few studies, I can
There are.
show you, yeah, that
Ah,
they are basically, when you sandblast it, it decreases the longevity.
I'd like to see those.
Yes,
Okay.
I have them in my laptop. So, implants in the aesthetic zone. So this is one of the things that I love to do. However, sometimes it goes out of the control. It doesn't matter what you do, at least in my hand. Whatever I do, I may not be able to get that aesthetic, mostly the pink aesthetic that I like, the soft tissue side. So the key factors for success is definitely the first one is the ideal implant placement. An ideal implant placement is the depth, and also in the aesthetic zone, you need 2 millimeters of restorative space and 2 millimeters of the soft tissue. And obviously, to save that soft tissue, you need a thickness of the bone. I think that 2 millimeters to be able to keep that bone so you don't get any recessions. And then ideal restorative space is 2 millimeters, soft tissue thickness is 2 millimeters. If you have that, anything works. If not, believe me or not, always under the thin soft tissue, you will see that grayish color. And that's a light reflection of it. So if I see a case that I don't have that soft tissue thickness, the only thing is that has a
Fourth.
optical property and the mechanical property, zirconia abutments. And I all know that. I mean, zirconia to the implant.
He was, I was.
Yes.
That is.
Grading, everything, but some
He was there, I mean, he looks good, but he can't.
in some cases be high aesthetic demand. And I, implant was placed, but I use
No.
zirconia abutments
Yep.
to my implant.
Right.
And I don't even use a hybrid.
Yep,
If I
thanks for
can't
the
use a
call.
hybrid,
Bye-bye, go blue.
even enough thickness and restorative space, then I use the gold with cemented zirconia on top. So as I talk about that, the criteria for that, I'm talking about, to be honest with you, soft tissue more, not, you still sound is good, Yeah, so the pink aesthetic, the soft tissue aesthetic is more important because I believe that in a good hand of any technician, if your technician understands ceramic, they can match it. The problem comes here. If that soft tissue thickness is not 2 millimeters or more. So I used to blame my surgeon sometimes, but sometimes nowadays when I look at the convincing CT scan, they don't have options. They even do graft, and then I still see that it's not there. So that implant may be placed a little bit more proper. Now, as a restorative dentist, they have to be managed. And if metal abutments, at least in my hand, doesn't work in those cases, that the soft tissue thickness is not there. So the other ones I wanted to mention here, what is that attachment? One of the things around implants abutments that we see that, and nowadays, if you look at Dr. Romano's work or other people coming, they started to talk about the peri-implantitis. And now, because we didn't have it in the past, now we have been able to see them in 10, 15, 20 years. Now we see that, right? One of them is a resin, but there are different reasons behind it. One could be a tight soft tissue connection to implant abutment. So nothing can migrate down. Do we have that around implants? No. Soft tissue attachment around implants are not good. We don't have a strong, good connective tissue attachment. So epithelial cell attached to a smooth poly surface. But the fibroblasts, they don't. They attach to rough surfaces. And we don't have that because the concept of implants have been, polish it well. Maybe the top part of it. The more needs to be a little bit more rough. I'm not saying that just randomly. Study needs to come out to tell you exactly that roughness, which we started some. But that gives you a good connective tissue attachment. And not only that, if you have a strong attachment, it can support your epithelial attachment. So maybe you get a better papilla, or maybe those rules from contact point to the bone 4 millimeters papilla filling, if less than this not may change because now we have a good connective tissue to support that. So just let's see how it changes. Obviously, if the soft tissue is not there, the moment that I honestly change the abutment to zirconia, that soft tissue looks good and pink. And a study like by Marcus Blotz came many years ago about that light reflection penetrates inside, come back from the soft tissue behind the soft tissue and create that pinkish color for you. And that's why you get a good, nice result. Number 10 is basically a implant crowns. But I use the zirconia abutments because the soft tissue thickness was not there. Although I think that the prototype is not a very thin, maybe medium, not thick as well, but still I couldn't hide it. The moment that zirconia goes in, it's good. So we are taking some risk, but it depends on the patient. As long as I educate my patients about the risk and the benefits, if they accept it, I'll feel very comfortable to place it. And that's it. The key would be zirconia abutment. So as the 3D printing zirconia, I don't know the time, still I have time, right? So as the 3D printing zirconia coming out, I have to make sure that the soft tissue attachment to them is the same. So we did a study and we couldn't find any differences between the soft tissue attachment to the 3D printed one and the mid one. Now, the other part comes in, innovative part. Okay, they're the same, but can be improving by controlling the surface texture to get better connective tissue attachment. So look at this case for a second and tell me that which one is the implant crown and which one is not.
You've cut off the gingiva. How do we tell?
This is the answer. It looks great. The moment you remove it, which one is the implant? 8 and 9. And this is the toughest case ever. When you have two implants close to each other, even though you're apart 3 or more millimeters, trust me, soft tissue is not easy to get. Can I get rid of that black triangle? Absolutely. I can make a long proximal contact. Is it the way to make it? This is how your body is? No. Your contact, I am basically making, or I can use pink porcelain. This is not my point. I want to think a little bit out of the box. Is there any way I can get that soft tissue back rather than just accept the fact it is what it is? Make the contact point longer. No, let's see if it, maybe yes. If we change the texture on the abutments, maybe we can change that. And that's what I was trying to say. So we came with that concept that we all know that the epithelial cell attached to the polished, smooth surface, but fibroblasts are different. And that's the whole concept of that idea. We have to be able to create an abutment that has a polished surface for that pocket epithelial, and then the rest will be rough. However, it needs to be studied, come out exactly what is that roughness. And then 3D printing can create that. And then you may be able to get a fibroblast attachment to that. So we are working on it. We have some interesting preliminary data I can share with you. So actually, this is the abutment that you guys printed for me. We wanted to make sure that, okay, whatever we are talking about is practical. It's not just based on, in my mind, it's not just, fiction. So we printed that, and yes, we could print the abutments, zirconia abutments, with the specific surface texture on it. And then the next step was, if we create that surface texture, how the human fibroblasts will react to that. That was the next step. So we printed with a different porosity size. We looked at it, to be honest with you, when you start doing the research, you realize that how much of those data that coming in, it can really sometimes be questioned. So when we were studying, the reading of those cells on the samples over the time are very different. If you look at the 24 hours, you see the polished one, even on the fibroblasts are better. As the time goes by, we see that the porous one goes higher. And also the shape of the fibroblasts on the surface is very different. If you see very rounded shaped cells, that means that they are not very healthy. The attachment is done. If you see a stretched cells, that's a very good sign. It means that it's still coming in. So it needs to be follow up 96 hours or more to see that, but definitely you see that the porous was going up. And that's not the ideal porous. I cannot expose it now because we are still under that. We are looking to see that what would be the best porosities for that fibroblast attachment, not epithelial. If you want to do research, go for fibroblasts. The epithelial cells, we know that attached to the smooth surface. And this is the concept that we're working on it, and I put it in animation. And abutment goes in with the polish and the rough surface. So the rough surface attracts your fibroblast for a good connective tissue attachment, and epithelial will be attached to the smooth and polished surface. And this way you get a good attachment around implants. Hopefully that decreases the pre-implantitis and also give you a better firm connection, maybe supporting your epithelial attachment with a better height of the pregingival margin, right? Now, can be extended to something else. All of that I'm showing, you can't do that with milling. This is all 3D printing because that customized surface texture cannot be created with milling. It's limitation. So have you seen cases like that? That's one of the cases come you start scratching your head, right? Well, what do I have to do? So basically in those cases, you send it to surgeon, they do multiple grafts, you know, that blood grafts, and try to get it. Sometimes they can, sometimes they don't. But another idea is that can be really replace that missing bone. They can. You can take a cone beam CT scan, the same way that you design it, you can design that piece of bone with the shape of the missing one and extract the STL5. You can extract that STL5, use a material, it's out in the market, that has been approved by FDA as a device. I think that they categorize it as a, they have a second device, the one that you have to look at. They have a different FDA application for that. And then you print that with a specific surface texture. And that can be placed back there. You don't need to remove it because material is biocompatible. It just stays there. And then soft tissue with the texture we talked about can grow on. So if you know that you don't want to get epithelial attachment, you make it polished. And if you want to get some connective tissue attachment, it has to have some texture on it. And that in most cases, even when you have a bone, have you seen your implants? If you follow up your anterior implants, they're coming after 2 years, you see that you don't have that scallop for tissue anymore. It's flat. The bone is there, soft tissue is there, but it's not really very natural looking because you don't have that bone structure under them. And that's what we try to do as well. So if you go back, this animation shows that. This is what, and they have been printed that as well. So that piece goes, has a separate texture on it, ideal separate texture. When the bone, it's basically replaces the bone, you never remove it, and the soft tissue has an affinity to attach to it. It covers that up, again, with the technology. So we looked at the basically fibroblast proliferation on different 3D printing ceramic, the biocompatible one. Actually, there's a new one I can introduce as well to you. This is the silicon nitrate. That is a very strong material. It has a little bit of grayish coloring to it, but it's a very good material for biocompatibility. It's very strong as well. You can 3D print it, and the soft tissue has a very good affinity to it. And if you look at the fibroblast cells over the silicon nitrate, I think that if you're in implant dentistry, you will see that material coming soon for replacing many things. Maybe titanium, that's my assumption. There is no evidences behind that, but I can see that with the properties and all those papers coming with the titanium particles in different parts of the body, I can see that that could be the next generation of the implants material. And this is the fibroblast attachment to it over the time. So in basically conclusion, 3D printed ceramic preliminary data are very promising. Mechanical properties are comparable or outperforming the milling one. Accuracy of AM ceramic has been improved and clinically acceptable. It is in the range of ISO standards. Optical properties have not been investigated. So that's a very nice research area to look at about the translucency and optical properties of it. Data on biocompatibility are very, very limited, to be honest with you. Technology, I think that still needs to be improved. I think that single material printing is not the way to go. Multi-material printing is the future in any material we use. And bonding to porcelain needs to be improved. We did a study, we published that for some reason 3D printing ceramics does not bond well to the porcelain. I think because of the remnants of the resin, it needs to be cleaned completely before you apply porcelain. Otherwise, it works as a contamination, may drop the work. However, with a new zirconia coming out, Y5, Y8, we may not need that because we go with a staining technique. And the potential of this technology, in my mind, is really, really unlimited. So we published a chapter, you know, the other author too is very good in digital dentistry. So it's in that book, and we wrote the third chapter, fourth, on the 3D printing. So I know that my time is done. I have another piece, if I have time, about the multi-layer, another concept of chemicals. It's not there for ceramic yet, but it is there for resin, and we have done that. If you think that the time is fine, I can go. If not, I can stop here.
Sure. How long we can?
I can possibly finish it in 10-15. You okay with that?
Go for it.
So let's talk about something else too very quickly. Survival rate. Why your enamel lasts so long and my ceramic doesn't last long? Why somebody gets the central incisor when they're 6, 7 years old? I see them, they're 78 years old, and it's a little bit of a chipping here and there, but it still is there. If the ceramic works for 20 years, I will be more than happy. Why is that? I think that you are going against the nature. Your enamel and dentin has properties that when you create a ceramic restoration, you don't pay attention. Your enamel and dentin is a graded structure. Did you know that, right? Your dentin have a low modulus of elasticity, low hardness, flexural strength is less too. Your enamel is hard. That's it? This is what most of the dental material books talks about, but that's not the fact. It's more than this. Your enamel by itself is a graded structure. If you look at the papers, the enamel close to dentino-enamel junction, the mechanical problem is more close to your dentin. As you get to the superficial enamel, and that's why your bond is good with the superficial enamel, not good with the deep enamel. As you get to the layer, to the surface, enamel property changes dramatically. And that change is not sudden. It's a graded structure. Start with something very flexible, goes up. And that could be the key. Not in our field, but if you look at lots of engineering field, that graded structure concept is very, very well established. We don't use it in dentistry. We're trying to find something, the most strongest one. Can a metal tire work under your car? No, honestly, can. Can you put a chain and drive with it? Which one wears out faster? A plastic one or the metal chain? Metal chain is gonna destroy in less than 100 miles. But you work it 10,000 miles or maybe more on the real tire. So being a strong material, it's good, but not always. And nature has an answer to it. So your enamel is a great structure. When you start it from here, it's soft. When it goes back, it becomes very hard. And it's a very structure. So can we mimic that structure now and look for more longevity? Maybe yes. So we looked into it. The first step was actually we have a pattern again. You know the other one as well. So Dr. Lee and then Dr. Morton, you know that. Yeah. Very sharp. So if you look at it, the concept is that you have to have different layers because that may work more under the pressure. When you put pressure on it, instead of cracking it, it bounces back and forth. Not always good because it reduces your forces, mastication forces, like full denture on the soft tissue. but it's basically stop the cracking. Let me tell you an example. If you don't use any metal bar, and if you use a fixed detachable, fixed complete denture over 5, 6 implants, how long do you think that is going to survive? Pure acrylic. 6 months, a year? Why your denture doesn't fracture every 6 months? Because it's sitting on the gum, which is flexible. Takes the absorb the forces. The concept of fixed rather than removal. So that was the concept that became with that idea. And basically, idea is saying that when you place it back there, right, it absorbs the shock. And if it can create it in our ceramic, that may last longer as well. Mostly on the implant, because the fracture of all ceramic on the implant has a higher rate. Again, rigidity. There's no PDL, right? That may, but the question is that can be created. The first step is STL file. I want to bypass it. It's just explaining about the statuses with a different reservoir, but we have that technology for resin today. I bypass it. So we publish papers, and you again know the other one too. So, and we created that STL file. We created STL file on the thickness of 2 millimeters with 20 layers, and each layer is about 100 microns. And we use different materials to print that. This is how we print it. When you have a jet printing, you can mix and match. So we put in one reservoir, the hard material like enamel, the other one soft material. And then we started to print from the Intaglio. The first layer, pure dentin. The second layer, 90% dentin, 10% enamel. You can do that with the 3D printing. 8% dentin, 20% enamel. When you get to the top surface, the last 100 micron pure enamel. So that's a great structure. And we, it took us 2-3 years. You may not believe that, but yeah, we finally created that structure. I think that this was another paper just came out 2 months ago that we actually measured the mechanical property as well and the internal fit of those crowns too. So we created that crown with the same concept that I told you, starting from Intaglio, completely zero enamel, full dentin, 100% enamel on the top, and that was the crown we created. You can actually add color into it too. Each layer can be printed with the different colors, and that was the crown on the die. And look at the crown. I presented in Academy of Cross. I got lots of feedback from Dr. Jacob. So you see it's hard, you cannot, but the moment that you take it out, look at what I can do with that one. Goes back. Because outside is work like enamel, very hard, you can chew, but at the same time, it doesn't crack because it has a great structure in it. We measure a couple of things on it, and we measure the bilayer, graded and solid one. We look at internal gaps. So this is the start point of it. I'm pretty sure that before that technology becomes available for clinical dentistry, needs at least another 3 to 5 years. But I mean, we have to start from somewhere. Otherwise, we would still do that PFS, right? And that was the graded structure, the mechanical properties. You can look at that paper. That paper now is published. Now, again, we did that as well. So we created a model to see that we can play with the mechanical properties. Yes, we can. We created different porosities. This is ceramic. The ceramic with different mechanical, with different porosities. As you change the porosity inside the zirconia, 5%, 1%, you can very easily play with the mechanical property. So now, statistically, we know that, for example, how much porosity we have to have in order to get that much of flexure or hardness or modulus of elasticity. And that was it, that concept. I'm not sure that can be easy integrated to the ceramic, but I'm pretty sure technology will get there very soon. So thank you so much. If you have any questions, or the audiences in the Zoom, if they have any questions. Thank you.
Any questions? No. Okay, we have one.
I'm sorry. 3D ceramic printing is not available on the market right now, am I correct?
It's in the United States, it's not FDA approved now. However, I can basically tell you that they're working on it. It's not only 3D printing zirconia. I think the Ivoclar will come very soon too. They are going to print their lithium disilicate.
I have a 3D printer that's hybrid right now. How long do you think it will take for the ceramic 3D printing to be available on the market in the United States?
To be honest with you, my understanding is at any time. Could be tomorrow morning, could be a month from now, and very, very soon will become available. This is yeah. If you have any
Our FDA clearance will be submitted in the next probably 6 months, if not sooner. And we're basing it on a predicate for using a printed zirconia for a veneer. So it's fully biocompatible, the material we're using. We're just printing it for copings, abutments, and full crown restoration. And we should be able, because we have the research and all of the data that Dr. Zandi has done, the research that Rama and Dr. Al-Rashdan has done, there's a lot of data that's been collected that we should be able to get FDA approval quickly. The printers are available. The printers can do mass production now, but they don't. I don't think you'd be able to do like a chair side level 3D printer would be able to do the level of detail that we need to create some of these shapes and structures. That would be the challenge on that. And then with full ceramic, after you print it, you have to fully debind it, burn off all the resin, and then fully sinter it into a solid monolithic ceramic or a varying porosity ceramic, depending on your application. That technology or that skill set is left up to ceramicists and material scientists to be able to make that so that it can be done faster and more efficiently and controlled. Right now, it takes about 7 days to do from printing to final finished ceramic. So each batch would take approximately 7 days from, okay, we're good to print, we have a good scan, speed that scan to the printer, print it out, and then finish it, clean it, debind it, sinter it. Takes about a week to 10 days.
Now, I have a question. You said that the hybrid printer. So what is the ceramic you can basically paste, you can add to it? If you don't mind, if I ask about that.
Wait, I'm sorry.
What was that hybrid printer you said about? That you have a hybrid printer that can print ceramic?
No, my question to you is, as far as I know, here we cannot print. We can print hybrid restoration right now.
When you talk about hybrid, you're talking about the ceramic reinforced resin or resin reinforced ceramic.
Yeah.
Okay, I got it. Okay, I got it. Yeah, sorry, I thought that you were talking about printer. So you're talking about hybrid material or high content ceramic resin, something like that.
Yeah. And you're talking about
Pure, the one that you're talking, a sprint ray can do that.
yeah.
So
that's what I have a sprint ray. So my question is, number one, when do you see that happening here? Number
The
two,
printers are very different. So the material that you are, so they market it, and I know sprint ray very well. And I know the people back there, they're really smart people back there, and I work with them. But the thing is that this is not really a definition of ceramic. Ceramic means density of the ceramic. You don't need anything else in it. What we are talking, it's a resin reinforced ceramic or ceramic, however they change the name. It's kind of hybrid or, and the first patent was rejected 15 years ago, was from our group, that we basically infiltrated the resin inside the porous ceramic. But that's not the definition of ceramic. That's a hybrid material, and that's in the market. The ceramic printing is completely different, and those printers may not be compatible with the ceramic because, and also the post-process is very different. You don't have that much post-process. You take it out, cut the basically supporting bars, you take the excess resin out, cure it, it's ready to go to the market. However, the ceramic one is very, very different because you have to do two firing. Debinding takes all the resin out, and then crystallization. So completely two different printers, two different concepts.
And that's a 7-day turnaround for that.
Yeah.
Roughly, yeah.
Yeah.
So I think in a dental lab type setting, if you guys are going to work in a full dental lab to build these restorations and customize them for patients, that dental lab setting would be the ideal setting for a full zirconia or full silicon nitride dental replacement implant to be manufactured. Would probably be in a lab, not in a office or chairside type setting.
I think so too, at least for now.
Yeah.
Yes.
Just because of that post process, that debinding, sintering, there's a skill set that needs to be technical
Yeah,
sensitivity. Yeah. Okay.
Thank you, Dr. Seeger.
Thank
Thank
you.
you for your time. Sorry for taking.
Wonderful presentation.
Thank you, Dr. Seeger.
Well, thank you again, Dr. Sandy, for your great presentation. So last but not least, I'm very honored to and proud to present Dr. Al-Rashdan, our very own Dr. Al-Rashdan. She graduated from University of Georgia in Science and Technology, and then she just recently finished our advanced education prosthodontist program at the University of Michigan and was recruited immediately as a clinical instructor, now doing wonders with our pre-doctoral dental students. So today, Dr. Al-Rashdan is going to share her experience with her master's project on 3D printed zirconia and the application of implant dentistry. So Dr. Al-Rashdan, the floor is yours.
Thank you. Thank you, Dr. So hello to everyone who's still here, and thank you for coming, Dr. Zandi. It was honestly very impressive, really impressive, and just very eye-opening. Now, this presentation, probably some of you have already, seen this before. I'm not going to go over the literature view because you both kind of covered it pretty much. I'm just going to be talking mainly about the bonding of zirconia over here. Now, this project in specific was I would say sponsored, or it was supported by, of course, University of Michigan, by the APP, Nobel Biocare, and by 3D Ceramics Center. So retention of milled versus 3D printed zirconia of 3 different Intaglio surface characterization bonded to pre-treated tie-based abutments, and it was an in-vitro study done here at the University of Michigan. Now, to begin, we want to start with. Okay, so I'm just going to say that the presentation outline, I'm going to talk briefly about zirconia. I've already covered that. Additional additive manufacturing, bonding zirconia, we're going to talk a little bit more about that. And then we're going to go to the aims, objectives of that study, materials and methods, the results that we got, and the conclusions. Starting off with zirconia, as we mentioned, this is a metal oxide, so it's zirconium oxide. Very biocompatible material. What's fascinating about it is that it is present in 3 different states, depending on the pressure and the temperature. So starting from monoclinic to tetragonal and cubic, at different temperatures. We all know in dentistry, we want to maintain this material in the tetragonal phase just because it has the best mechanical properties over here. As you can see over here, as it transitions between the monoclinic to the tetragonal, there is kind of a 3 to 5% shrinkage. And if that material cools down, it tends to kind of expand back to the monoclinic. And this causes a lot of problems in terms of crack propagation and formation, of course, and then with use, it just propagates, and then it really limits the longevity. So research have already given us some ways to actually stabilize that material in the tetragonal phase, and that's by adding those oxides over here. The most common is the yttrium oxide. It really just stabilizes that material in the tetragonal phase, preventing it from actually drifting back to the monoclinic phase. And that gives us the the understanding of fracture toughening property of that material. So if you see here that diagram with that tetragonal, with that zirconia, which has been stabilized already, we have those white particles, which are in tetragonal phase. Let's say this material was subjected to some sort of force a long time with, let's say saliva as it's being used inside the mouth, a crack might actually form. Those yttria particles, they have enough stored energy to make the tetragonal zirconia undergo phase transformation to monoclinic. So as you can see, closer to that crack is where that monoclinic transition happens, and that monoclinic just holds that crack there and prevents it from propagating. So just because once it becomes monoclinic, it kind of expands. So it kind of acts like a pressure onto that crack and closes that crack. So that's the whole concept of, having a stabilized zirconia there. Now, manufacturing zirconia, we've already talked about that. There's the subtractive manufacturing, and that could be a hard mill or the soft mill. There are pros and cons for each. Soft mill, of course, we do the sintering afterwards. So there's a 20% shrinkage that happens over here, and that should be accommodated into the design. The hard mill over here, it's already pre-centered blocks, and this really just wears our burrs really quick and also kind of introduces some also cracks there. The other one is the additive manufacturing. There's plenty of, manufacturing techniques. We're not really going to go deep into them like last time, but probably the most advantage over here is we're really reducing that waste in the 3D printed, in the, milled technique, and we're creating those very micro geometries that we cannot really achieve with that, with the milled technique. So additive manufacturing, it's defined as the process of joining materials to create parts from 3D model data, typically layer by layer, in contrast to the subtracting manufacturing method. Just in short, how most of them work is we do have the 3D printing technique, regardless of which technique we're using, that goes layer by layer. You can see there's a binder over there. So we do have like an organic or inorganic binder, and then the actual powder, which is that ceramic powder that we're looking for. That binder, it acts like the scaffold that just holds the material together. And then once that is printed, we call it, it's printed in its green state, it goes under the debinding process, and that usually takes several days to get done. And then at the end, we go ahead and center that just to get those particles good together and just to solidify that material. So this is how it usually goes from green state after debinding, and then once we get that final product after centering. As I said, there's multiple additive manufacturing techniques for us in specific, just because we use that in our project. We're going to take, to talk about the SLA, and I think they've already covered that for us. It's basically having that build platform descending downwards each layer. So you have the resin covering, the lasers solidifying whatever that FCL file has, and then the platform kind of descends downwards, exposing a new layer, and that would be solidified as well. Now, as for bonding zirconia, can we actually bond zirconia? So if we look at the material itself and compare it to Lincoln Dexilic, it is a crystalline, polycrystalline structure devoid of that glass material. So bonding has been a challenge for zirconia. Multiple people have, authors have demonstrated what could be possible, surface treatments that we can do in order to enhance that bonding. First was the hydrofluoric acid etching, but that was really advised against, just because that acid does not really enhance the bonding efficiency. It actually really changes the composition of the material. So we didn't really have good bonding strength with that material in specific. Airborne particle abrasion, and that's usually using aluminum particles. Now, some actually advise against using this type of surface treatment for zirconia in specific, because of the same reason that was mentioned before, is you are introducing those cracks. If that pressure is not really controlled, and the size is not controlled, and even the duration sometimes, it's really hard to control this time. So they do advise against it, although there are clinical scenarios where we do air abrasion to zirconia, but for the sake of here, we wanted to actually eliminate that because there has been good research that supports it. Versus the last thing, which is the MDP containing resin cement, and that's where we're heading over here, is to have a cement that contains this particle. This particle in specific, it has a very long name, but I never read that name, but anyhow, this is how the particle looks in specific. So if we take a look at the groups that we have here, we have the polymerization group, the hydrophobic group, and the hydrophilic. The hydrophilic here, it contains the phosphate group that really links to the metal oxide. And then from the other side, which is the polymerization group. It has the vinyl group that reacts with the resin itself, which is the cement that we're going to be using. And then you have that hydrophobic group that really separates those two together. And this diagram in specific shows how this MDP links to the metal oxide from one side, and then to your resin cement to the from the other, through that phosphate group, the vinyl group, and all that. So in terms of the bonding protocols, if we want to like standardize the bonding protocol for zirconia, and specifically for this study, it was recommended just to have the zirconia crown to clean that intaglio completely with alcohol, make sure that it's completely dry, use an MDP containing resin cement, and then maybe air abrasion for, let's say, for those titanium abutments, since we're using titanium abutments here, maybe do that air abrasion for that titanium abutment instead of that zirconia crown. And that's what we actually did. But does this actually apply to additively manufactured zirconia? That's where we wanted to actually see, do we have that similar bond with the additive manufactured zirconia versus the mill? So what are the available literature on the bonding of the printed zirconia? It is pretty much scattered between with and without. We do have some with that are with and some that are without, against. So the first category, they did see satisfactory and adequate bond strength between 3D printed zirconia and the veneering porcelain. And they compared favorably with the milled compartment versus the other one, which we kind of talked about just briefly. There were weaker bond strength of the additive zirconia, additive manufactured zirconia when compared to the porcelain veneers and composite resin. However, the reasons for that, or for that variability, is basically it was attributed to the brand of porcelain that was used, and also the surface pretreatment conducted before adhesion. So we couldn't really get like a conclusion on that. We wanted to test it ourselves as well. And as just to let you know, this project did take some time. So I was kind of viewing the literature before and, throughout this project. And right at the end of my project, those two articles came out and they kind of incorporated this surface textures that we were kind of talking about, or their microstructures. Here they use hexagonal shape, or they call it the frog. I don't know, I forgot what it is, but so they did have that design, and they did mention that it led for that bonding material to actually be more integrated into the zirconia material, and maybe that could be that could add or enhance into the bonding efficiency. So this takes us to the aim of our study. Here, we kind of worked, on what type of shapes we want to incorporate it. We kind of chose this specific design, which is the inverted pyramid design, having that apex towards the bulk of the zirconia material, and then we have the base, which is going to be directed towards the tie base itself. Now, we wanted to incorporate that design, and then if you can see here, it's going to zoom into, it's not really showing here, but it's going to show in the other slides. In this case, we wanted to do the inverted pyramid design for two reasons. So if we didn't have that, if we don't have that apex actually touching that tie base surface, in order to prevent any, probably those pointed edges are going to be, abraded, and we didn't want to do that just because it's going to create even more space between our tie base and the zirconia. And the other reason was exactly like Dr. Zandi mentioned, which is we wanted to mimic this direct restoration bonding technique, which is once we actually remove that smear layer with our etch, let's say, we are exposing those dentinal tubules, and we are having those composite actually integrating into our dentinal tubules. So if we kind of mimic the same thing with our restorations, we might actually have a good chance of getting this robust bond. So here it takes us to the objectives of the study, which is we had two objectives. First, we wanted to investigate if there's a difference in retention strength between milled and printed monolithic zirconia copings that are bonded to tie base abutments that were previously pre-treated with air abrasion. And then our other objective is we wanted to see if there's an effect of any of those digitally designed microstructures in the intaglio surface of that printed AM zirconia, or additive manufactured zirconia. So materials and methods, here we had Nobel Body Care implants, Nobel Parallel, and we had 60 implants with 60 universal tie bases. We used 50 microns aluminum oxide with a pressure of 0.25 megapascal, and we kind of air abraded those the fitting surface of the titanium. We had zirconia being milled by this brand over here, Apsara. And then we had the additive manufactured zirconia over here by 3D Ceram. We had 15 per group. As you can see, the additive manufacturing, there's 3 groups, one with no surface modification, and that's going to be exactly the same as the subtractive because you can't really do any surface modification with just milled. And then we incorporated those microstructures having 120 microns and then 240 microns. These are the composition of those 2 materials. I mean, we can look at them, but maybe later. So going back here, the mills, I just listed the equipments that were used over here for the milling and then the centering, and then the same for the additive manufactured or the printed, the printer, the debinder, and then the centering machine. Now, the project workflow over here was very much interesting and very funny. We wanted to mount those implants very much parallel. So when we go ahead and do our pull-ups test needs to be completely vertical and eliminating those lateral forces. So we kind of did a design over here where we got a stainless steel ruler. Doesn't really flex, it was with good thickness. And we did those holes inside them that correspond to the impression copings that are gonna be screwed onto the implant. So, and we laid that very flat. You can see those 2 platforms that we added. Those 2 platforms added, we wanted to raise the platform of that implant. So our resin would actually start 1 millimeter below the platform of that implant to kind of mimic the bone loss technique kind of situation. Now, we did this for all the copings over here, and this is like a zoom in of, the platform of the implant. You can kind of see there almost 1 millimeter, and we make sure that our mounting is completely parallel or perpendicular to the floor. So this is what we had over here. We had all of them, we kind of report just for the sake of, we wanted good length over here. And then we attached our tie bases, sandblasted those. We kind of wanted to mimic the screw mentable situation, so we didn't torque yet over here. This tie base we used an in-office scanner over here just to scan. From that scan, we can generate that STL file, and I think we worked closely with Dave over here. I think it was SolidWorks that we used, because that's what I was told. And then we did our design over here. It took us some time just to get to that design, but we finally made it. This is the 3D sample that, we made, and this is how it looks on the inside. As you can see, those inverted pyramids, it's really hard to see in real life. I think you have to zoom in. Those are the printed samples over here. I don't know if you're gonna see, I kind of scratched them with pencils, so you can see that there's like zigzag figures, and you can definitely see those wings over here, which correspond to our wings that are already there on the universal tie base. We went ahead and we cleaned those surfaces with alcohol, no treatments. We did not treat the zirconia surface whatsoever for milled and for printed. And we went ahead and used this a multi-link hybrid abutments resin from Ivoclar with the primer that contains this MVP. And this is what we got. We had everything cemented and ready to go. This is a zoom in. We cleaned that excess cement. We made sure that there's nothing, because sometimes that interferes with our, pull off. It may give us some wrong readings. So we made sure that it's completely clean. There's no excess cement there. And we let them for 24 hours to set before we go ahead and do the pull off test. At this point, we made sure to torque these in just to simulate the screw-mentable kind of screw-mentable situation. Then we went ahead and we loaded those onto our Instron machine. We kind of ordered specific side screw action grips for that. This gave us a nightmare just to figure out what to do. We ended up doing a custom-made jig that really is very precise to our coping over here. As you can see, that slot is where that coping gets in. That's why we kind of left also those 1 millimeter, because it kind of slides in there. And then when the pull-off test, and then I'm going to show you how it's mounted. When we do our pull-off test, we're kind of just loading those 2 extensions. This is made out of iron, and this is like 3 millimeter thickness of whatever the grip is holding. So nothing is really flexing. This is a very solid and rigid material. We went ahead, we did our testing, and it was 0.5 millimeter per minute. And we had a 5K Newton load cell over there, and we did our pull-off test. This is a zoom in of how it looks. You can definitely see we're not really loading before loading that sample before doing the test. There is like a very minimal space between that coping and the platform that we have over here. So our force is mainly centralized towards our tie base specifically. Now the results are really interesting. First, we kind of did the QQ plot test to make sure that we have a normal variation between the tests, and we did a one-way ANOVA test over here, and this is what we actually got. So we comparing all the groups together, you can see that there wasn't really any statistical or difference between SM and AM, and here SM and AM is the milled and printed, no surface alteration, versus when we go to the 120 and 240 surface alteration, that really significantly made a difference. But a one-way ANOVA with this, because our sample size is quite limited and it's very small, we went ahead and did t-tests for each and every one of them, and that was an interesting point. So for the first one, we wanted to compare the milled with the printed, no surface alteration. And with that t-test, we can actually see they're very, very close, but there is that significant difference between them. Not so much, but it's still there. So for our question, our first objective, was there a difference in the tensile strength between milled and printed? And yes, there was. So we went ahead and we kind of rejected our first null hypothesis. Going to the other groups of the printed. So we wanted to see, okay, we didn't have a better bonding compared to the milled, but if we do those surface textures, are they going to really enhance that bonding? Yes, they do enhance that greatly. We had numbers going up 1600s. So it was amazing, the numbers that we got. Did it really differ between the 120 and 240? Not really. Is it really necessary to go all the way to 240? Debatable, I don't know. But just going back, did visually design microstructures in the intaglio of the printed zirconia influence the bond strength? And it did. So we went ahead and rejected our second null hypothesis. Just for the fun of it, we kind of did a t-test or we kind of did also testing between the milled and the AM surface textures. So this is where it actually made a difference. If we wanted to use additive manufactured zirconia, maybe it's not worth it to just do additive manufacturing without any surface texturization. Versus if we added some textures, it actually surpassed the milled copings, and that was the breakthrough over here for us. So for conclusions, within limitations of this study, we want to conclude that first, yes, AM zirconia or printed zirconia did not perform as the milled zirconia. However, once we added those microstructures, it really influenced the bonding efficiency of the additive manufactured zirconia, but it even also surpassed the milled copings, which was very interesting. Now, for the limitations, of course, it's an in-vitro study. It's a preliminary study that involves static loading. SEM microscopic analysis was not performed, although we will perform it. Future recommendations, we want to see the effect of different surface treatments. We want to see the effects of different cementation protocols, and maybe long-term clinical investigation. And that would conclude my presentation.